Great talk. Tough case, great outcome. The mics are opened, and we're ready to take comments or questions from the audience for our panel. Dr. Sailors?
Yeah. Dr. Upchurch, you made some comments on the 4 to 5 centimeter aneurysms. I'm not one that operates on 4 to 5 centimeter aneurysms, but you gave data slides implying that they may have been inappropriately operated on, maybe not. In that data, do you know, is there a subgroup in there that have growing aneurysms that, you know, maybe they're in that 4 to 5 centimeter range, but the aneurysm is growing abnormally, yet at least it's projected the way it was presented that they were inappropriately operated on? So do you have that kind of information? Do you have any comments on the growing aneurysm?
So I'll answer your question by asking a question. Has anybody in this audience ever looked up the data on aneurysm growth rate and rupture risk? If anybody's ever done that, raise your hand. And
I think everybody has.
Okay, so
but it's a little bit. I guess you have to understand the growth rate of an aneurysm. I mean, there's studies from Malmead that go way back. You know, and the average growth rate, general rule, 0.2 to 0.3 centimeters a year is what you'll find. You see some 0.17, you'll see some ranging, depending on the size of the aneurysm, up to 0.7 to 0.8 centimeters a year. But we all look at that information, and it's hard. It's not just a fixed rule. So given the presentation and the comment, and then given the commentary on how reimbursement may be affected if somebody's denying, you know, or saying that you shouldn't be operating on that group, then I think as leaders, the question I have is how deep are we deep diving into this subset of patients, and what is driving surgeons to operate on them?
So let me first of all say, I've operated on aneurysms that are 4 to 5 centimeters, so let me not be so self-righteous sitting up here. I was using that as an example of actually understanding guidelines. That guideline is a weak guideline with functionally little to no data supporting it. And yet 40% of aneurysms are fixed in that area. I didn't really address the issue about aneurysm growth. The thing I know about aneurysm growth is the larger aneurysms grow faster. But I also can't tell you whether it's 2 millimeters per year or 3 millimeters per year or 4 millimeters per year. I don't know what accelerated growth is, and it's probably different between the abdominal and the thoracic aorta. So I would just say, part of this is you managing your own practice and your own patients. I've had a patient come to my office once when I was at the University of Michigan who was a missionary, and he had a 4.7 centimeter aneurysm. He said, if you don't fix my aneurysm right now and I go die in the jungles of Honduras, I'm going to haunt you for the rest of your life. So ask me if I've ever fixed an aneurysm that's 4 to 5 centimeters. The answer is, of course I have. I just want people in the audience to recognize it probably shouldn't be 40% of those aneurysms that are fixed, and you need to think about it. Whether that means you screen the patients more often or you see them back in your office and do aneurysms. I'm just saying, we are the people generating the data, right? We are making, and we're supposed to be the managers of these patients with aneurysms. It gets back to what Mal was saying. We will, you know, this is our disease. If we do right by it, it will be recognized. And so I think that's just a really important thing. I mean, is 40% okay? I don't know. I don't know what CMS. I don't think like CMS. I think like a vascular surgeon. So your points are all very valid. I'm not self-righteous in telling you. I'm just providing the data. Except for when it comes to Will Jordan, fixing small aneurysms.
Thank you, Gib. You're not just providing the data, you're providing some editorial comment, and I think that's really where David was going with it, because it's a very important concept, and I think it depends some upon how that message comes out in the reports. Sal Scali's brilliant, but the report makes it act like we are over-operating, and so I have a couple of questions, and I think there are a lot of panel members that could help with this. One is the VQI data set really designed to pick up some of these numbers so we can identify that problem? And I say that because I've seen errors in VQI when those diameters are mislabeled, or they're picked from some other location that it's not really fully understood. Lastly, I think a broader concept, Mal has promoted more screening, great idea, but more screening is going to lead to more aneurysms and likely smaller aneurysms being treated. I'm sure you can also cite the publication from UAB that showed how the small aneurysms actually do better, and people argue because maybe you don't need to treat them. But I don't know, we're caught in this conundrum. We want to screen more, treat more, but then we're also getting another message we're over-treating. And the last question, Dr. Weaver's here, Fred, you can help us, is VQI the right instrument to help us figure that out? So thank you all for being here. I hope that will get some discussion going.
I'm going to make one more comment, and I think this is really, you bring up a really valid point. I don't know how many people have seen Bruce Berler give talks about carotid endarterectomy versus carotid artery stenting. And he always says that the data for carotid, or medical management, but he always says the data for carotid stenting is getting better and better and better. But the data for carotid endarterectomy is also getting better and better. And so we have a 1% combined stroke rate, death and now for carotid endarterectomy. My guess is the same is also true for EVAR, that we don't have a lot of the data was sort of based on a European trial where mortalities were actually higher. My guess is we're doing better and better on EVAR, and the mortality is probably going down. So maybe we should actually be lowering our threshold for AAA repair, and maybe the data's lagging. I'm going to let Fred talk about the VQI.
And remember, the Brits tell us we shouldn't use EVAR for aneurysm repair unless it's ruptured. And I didn't see, there is a good paper out, and I think it was in New England Journal or one of those. It's about 5-6 years old. That showed the per capita mortality rate for aneurysms is substantially lower in the U.S. compared to the U.K., probably because we're more liberal with it.
Yeah, so as far as the VQI, Will, I think the as far as trying to answer some of these questions, I think the VQI is really helpful, specifically for the thing I posed with the popliteal aneurysms in females. I think it's more hypothesis seeking, but to really answer these questions, you need to have much more structured trials. I don't know that we'll ever get there. We do have, some obviously prospective trials looking at EVAR and open repair and things like that, but, observational trials of asymptomatic aneurysms, that's going to be a hard one. And the other issue that I'll bring up is that it's amazing how bad the follow-up is for post-EVAR, or even doing some kind of longitudinal study to look at asymptomatic aneurysms. Even in the most rigorous of trials, for the EVAR trials, if you actually look at just the numbers, not the Kaplan-Meier, but the numbers, the follow-up is awful. It's really not, we're talking about 50%, 60% at best at 5 years. And if you look at, I'll go back to the CREST trial, they did a 10-year follow-up. Their 10-year follow-up in the CREST trial, if you just looked at the absolute numbers, was around 25 to 30%. So I don't know how that's the practical issue with that.
Some patients don't like to see their doctor. I'm one of them. I don't like to go to the doctor.
No, and nobody wants to be told that their aneurysm is growing, right? I mean, to some extent, ignorance is bliss, right? Out of sight, out of mind, I'm fine, everything's great until I'm in the emergency room with a ruptured aneurysm, right?
That may get back to what Mal was talking about, and when patients get an EVAR, they think they're cured, and we know they're not cured.
This is a different question. I've been asked before in regards to lithotripsy and visceral artery aneurysms. That comes up occasionally especially with a renal artery aneurysm that's small, less than 2 centimeters, and we'll get questions all the time about the use of lithotripsy in that setting. Is there any comment in regards to that particular clinical scenario?
Lithotripsy targeting the aneurysm?
There So,
Oh,
so
and
in
if
the
there's a
setting of
risk
urology
to the
service
aneurysm
treating,
with lithotripsy.
and then and there's an aneurysm there sitting in the hilum of the kidney, and they have a panic attack. They don't want to do the treatment. But, you know, there's really not a lot written about that specific clinical scenario, and does anyone have any comment or information?
Yeah, I'll defer to the whole panel, but I personally don't know of any data, nor have I had any patient experience that I would prioritize the aneurysm in that case or issue any warning or guidance to the urologists. I think they're probably two discrete entities.
Dr. Jerry Cohen, Savannah.
Are they worried about the lithotripsy rupturing the renal artery aneurysm? Is that's really their concern, right?
That's their concern. I've had two scenarios in the last 2 years. Both times I said, yeah, go ahead, do your lithotripsy. Patient did fine. Yeah, it's flip a coin. And you know, research and looking, you can't find anything. So I was just curious if the panel had any experience or comments. Yeah.
I actually have an idea about that. Being from South Georgia, I just ask them how the shocks are on their truck, and if they're okay, I say, go to town. Dr. Coleman, I have a question about surveillance, because we all have a lot of nice little old ladies that are referred to us with 2-centimeter signet ring splenic artery aneurysms, and we see each other for a while, and we go annually, and it doesn't change, and then sometimes I go to ultrasound to see if they can see it to spare them the radiation. But I wonder if you could give kind of a pragmatic recommendation for the worried well that have a visceral artery aneurysm that will never rupture.
It's a great question. Thanks so much. I'm going to share what I do, but also share that that may not necessarily be what's built into the guidelines. I think your sweet little old ladies who are postmenopausal with these small aneurysms will probably never grow. If I have 2 concurrent annual studies that show stability, I'll get a Q3 year study. If the aneurysm can be seen by duplex, I favor that. If it can't, CT, non-con, or MR. The group that I look at differently are the younger women who may or may not have fibromuscular dysplasia, or those that still have hormonal influences that are premenopausal. I think those aneurysms are different, and so this is a scenario where I will probably follow them outside of what's recommended by the guidelines and sometimes consider treatment paradigms that are outside of those guidelines. And so I have a hard time not seeing somebody who's 45 with a distal renal aneurysm, you know, on a cadence that is 3-year cycle. And so that's what I do. The guidelines would support with kind of the null to slow natural history that imaging every 2 to 3 years is fine. The risk being that when you stretch your surveillance out to 3 years, there's data that shows you may risk some loss to follow-up for the reasons we're talking about now.
All right, we're going to take a few more questions and run a little bit over time. Dr. Chang?
Thank you, and thank you to all the speakers for their great talks. Dr. Sheehan, I have a 2-part question for you. So with May-Thurner syndrome, any thoughts about associated venous aneurysms with May-Thurner syndrome? And the second part is, do you have a favorite venous stent?
What was the second one?
Do you have a favorite venous stent that's not recalled currently?
Okay. Well, the first question I'll answer, yeah, I have seen a number of patients with venous aneurysms with May-Thurner syndrome. It seems that there are some patients, I don't know if you've seen these, but they are just, they have a venous aneurysmal disorder, right? They may have nutcracker and May-Thurner and popliteal entrapment, and I've seen this in pelvic congestion, and they're tricky to treat. But, you know, so I do see that, and there is this type of patient that definitely has that. I have a couple that I'm trying to figure out right now. I tend to prioritize the aneurysm, particularly the popliteal venous aneurysm, since it's so large and the thrombus burden can be so dangerous. You're really forced on those patients to treat them with lifelong anticoagulation or repair their popliteal venous aneurysm. So I do focus on that first, long before. But, you know, you wonder whether or not there is some type of genetic predisposition in certain patients for these grouped disorders. But my favorite stent is still the wall stent, although I do like the Innovo stent because of its precise deployment. just so much experience with the wall stent at this point. And I think it's so, it's tricky to use, as everybody knows, but if you use it often, you know how to use it, and it's pretty predictable for me. But the Inovo stent really makes a very big difference when you cross that inguinal ligament and you have to land right at that popliteal profunda vein. It's very nice to have that precise deployment there. So I do use those two stents. And unfortunately, the Z stent on occasion as well, the Cook Z stent, which I think is no longer with Cook. I haven't used that too often, but that is sometimes very helpful with giving a little bit extra support, radial force there in the IVC.
Thank you.
So one more last question for you, Dr. Sheehan. Gynecologist sends you a patient who has pelvic pain, non-cyclic. She's done a CT scan. There's a tight May Thurner. You can even on the CT scan see a lot of collateral flow, and she has no leg swelling at all. Her leg is completely normal and has no symptoms. What do you do with that?
So her symptoms are really just pelvic congestion symptoms. And so these are very difficult patients to try to figure out. Tends to be in these younger women, and so, you know, you would like for them to just get older and let the disease go away, if possible. I mean, that's what I'm thinking every time I see this type of patient. However, if they're really miserable and debilitated by their symptoms, you really have to pursue a little bit more diagnosis. You know, I will go in and do a venogram. I'll get pressures. You know, I'll look at the renal vein. I will actually put my IVUS in the renal vein, look at the gonadal vein, and measure pressure gradient. I have found that to be unreliable, you know, because you're looking for a 1 to 3 millimeter gradient in something that is fluctuating. So it's, I don't know how anybody can reliably see that. I haven't been able to find a gradient in these patients. And so it's very difficult to find out, is the problem the gonadal vein itself? Is that refluxing? Is that the problem? And would the patient be better off with having that coiled? Or is it the May Thurner that is leading to this pelvic, is it both? You know, and I know studies show that if you treat both the May Thurner and the gonadal vein, they may do better. There's a little bit improvement over either one of those alone. However, the improvement is only in the 60% range as far as symptoms. So, you know, I have treated patients where I've coiled their gonadal vein and treated their May Thurner, and they are no better. And that's really unacceptable. So there isn't a good answer that I can provide. I just try very hard to try to figure out how bad those symptoms are and what's the best approach. Some patients get better and some don't.
Yeah. All right. With no further questions, I think.
Chuck, I have a question
Oh.
for Claudia, too. You know, it really bothers me putting that big slinky, you know, in the iliac vein and then sliding it up into the vena cava. So my question is, do we have any long-term data on downside consequences of cable thrombosis? You did mention contralateral iliac vein thrombosis, but what about cable thrombosis? Because at least in my experience, my limited experience, you know, most of these patients that at least I've treated are by and large female and they're young. Mm-hmm. And so they got a long time horizon with that big old thing sitting in their cava, and that just bothers me just conceptually.
Oh, I know. I hate to put anything in. You know, that data really was, it included iliocaval thrombosis, that 10%. That study really changed my perspective on a lot of my patients and how to manage them and how aggressive to be. But there isn't, you know, that's the big problem with May Thurner syndrome. It's almost ridiculous how little data we have. We're doing this procedure. It's probably one of the more common procedures done across our country, and we have very little data to standardize any aspect of it from beginning to end. You know.
So like this is probably where VQI could be really helpful in the venous stent registry, which has kind of started and stopped and started and stopped. But this is where VQI, this kind of situation is something that VQI would help us get a handle on.
Yes, although the only problem is entering the data. The data is absolutely subjective, really. I mean, looking at the diameter reduction and cross area reduction and degree of compression, the shape of the vein, all of these things, they're you know, so subjective.
But at least you could get maybe 1 year, at least some relative of 1 year thrombosis rates or some
Yeah.
adverse consequences.
Yes, yeah, definitely.
All right, well, I thank the panel for great presentations and discussion, and we're all free to go to the exhibits